In this video, I'm going to dive into more of the evidence and the etiology of these rapidly reversible painful conditions. But before that, I just want to explain who I am and why I am qualified to teach you about this. My name is Brent Cunning. I'm an advanced practice physical therapist. I went to the University of Western Ontario in Canada and did an honors specialization in medical cell biology. I have a master's degree in physical therapy from Queen's University in Kingston, Ontario. I have advanced training in a diagnostic system called mechanical diagnosis and therapy, which is the most researched diagnostic classification system for MSK pain. I spent about 3 years triaging for over 2,500 cases of low back and leg pain for the spine and neurosurgeons in London, Ontario, Canada. In this role, primary care providers would refer patients to me before getting an MRI, injection, or seeing a surgeon. I trained directly with orthopedic spine surgeons and neurosurgeons, scrubbing into surgeries and learning their criteria for different types of spine surgeries. I also trained directly with interventional radiologists and anesthesiologists, learning the appropriate criteria for guided spinal injections. I trained with rheumatologists and pain specialists, learning about the various medications and dosages for different types of pain. I also learned how to interpret MRIs, CT scans, and radiographs for spinal conditions. And I have advanced red flag screening, determining when somebody needs emergent or urgent care. In this role, I would determine someone's appropriateness for exercise-based intervention, imaging, injection, or orthopedic surgery, or I would make recommendations to the primary care providers about further diagnostics or referral to another specialist consultation like neurology or vascular surgery if it was appropriate. And as I said before, the system that I use for diagnosing MSK pain is the most scientifically validated and reliable approach to MSK pain. It is actually relatively new. It is the only system out there that has completely characterized, defined, and reliably exposes rapidly reversible lesions. And the literature support is now overwhelming in terms of its intertester reliability, its treatment efficacy, its alignment with the biopsychosocial model of care and incorporating cutting-edge pain neuroscience, its ability to predict outcomes based on precise diagnostic categories, its ability to differentiate between extremity pain of spinal source and true extremity pain coming from peripheral structures. This is from a 2019 study showing the high prevalence of isolated extremity pain that is actually coming from the lumbar spine or the cervical spine. It's got support from multiple systematic reviews, and it can save costs on downstream healthcare services. We now have data showing that using an advanced form of this system actually reduces MRI utilization by 50%, injections by 40%, and surgeries by 78% for individuals with low back pain. So why are we using cervical and lumbar extension screening, and why is this particular movement so effective? Well, because we spend most of our day in the complete opposite direction. The world we live in pushes our cervical spine into protrusion and flexion, looking down at computer screens and looking down at phones, and we bend forward at the lumbar spine over 3,000 times per day. Rarely do we go in the opposite direction. Now, we don't know the exact physiological mechanism underlying this rapid reversal of pain phenomenon because pain is very complex and multifactorial, but one of the proposed mechanisms is that this frequent bending forward creates a hydrostatic mechanism within the disc, causing an asymmetric posterior or posterior lateral accumulation of pressure within the disc over time. And this accumulation of pressure within the disc can rapidly reverse once the disc is placed under an extension force, creating a hydrostatic mechanism for the pressure to redistribute in the opposite direction and take the pain away. And this can often lead to pain resolution within minutes, hours, or days. So this can happen within a single visit within your office, like the example with Dr. Kreutzer. I actually had another family physician tell me the other day that he helped a lady with debilitating low back pain reverse her pain dramatically from gardening the previous day, being stuck in flexion for a sustained period, just by talking to her on the phone and guiding her through a lumbar extension screen. So that's how quickly these things can turn around. This posterior and posterior lateral pressure distribution can mechanically irritate nerve tissue that's very close to the disc, resulting in not only local pain, but either the classic radicular distribution or this isolated extremity pain phenomenon that can mimic extremity joint and tissue problems. But you don't have to tell patients all of this information. A simple analogy will suffice. Just say that the point of this repeated movement screen into extension is to find out if you have one of these joint pressure asymmetries from sitting or bending forward too much. Now, there's no need to indict the disc here because we do have some data that shows that being very pathoanatomical heavy can lead to catastrophization, magnification, and rumination on individuals' pain, which can exacerbate their pain state, especially if an individual is more prone to this type of thinking, like people with anxiety or depression. So here's an example of how you can phrase this. Simply say, Look, the most common cause of neck and back pain is a stiff joint within the neck or the back from a buildup of pressure. The analogy here is that the joint is like a fence post that's stuck in the ground. And if you wiggle that fence post back and forth in just the right frequency and just the right force, you can wiggle the fence post free and significantly reduce your pain while also getting an improvement in your range of motion of your lumbar spine or your cervical spine. You can add, in addition to this, if they have arm or leg pain, either radicular symptoms or isolated extremity pain, that wiggling the fence post free can also unkink the garden hose, which is the nerve pain that you're experiencing. This is a great way to explain referred symptoms that are in the extremity that are actually coming from the spine. You can say to the individual, you know how when there's a kink in the garden hose, the problem is where the kink is, but the water that's coming out the end is scattered and disorganized. It's very similar to referred pain. The problem may be coming from your lumbar spine, but your body feels the symptoms in that distal location or that location away from the source. And you can say to the individual that the extension test that you're about to do is one of the most common ways that people can start to wiggle the fence post free and to decrease their pain significantly, increase their range of motion, and centralize the leg symptoms or the arm symptoms or abolish or decrease the extremity pain. Now, you should also say to the individual that doing this type of movement screen does have some risks associated with it. And that's that in a small number of individuals, this extension exercise can actually increase the pain intensity, decrease the range of motion, and peripheralize their symptoms down further into the leg and further into the arm. Just be sure to caution them that if they are experiencing an increase in intensity, and particularly if it's moving further away from the source, and they are losing range of motion gradually as they're doing this exercise, have them discontinue the exercise. That's it for the evidence, etiology, and the analogy that you can use to describe these conditions to patients. You're now teed up and ready to go to start using these particular screens.